while we're on that topic, do you think there are clinical benefits from a 16-8, just to use that example, time-restricted feeding pattern? So if you said to a patient who came in to see you, I want you to only eat between noon and 8 p.m., nothing outside of that, but you don't make any other change, do you see them get better?
We do. So I think that you would do better if you fix what they eat inside that 8 hours too. But if you take their diet and just squish it into 8 hours, I think that like we see people get better. Like we see people change a lot because as I said, we did sort of one meal a day where we squished it even further. And those people basically, they didn't even change their diet that much. We talked to them about it, but we didn't focus a lot on it. And if you actually probably were to ask them, my guess is their diet didn't change a huge amount. But just by squishing the time that you're eating, you're sort of forcing people away. And I think part of the issue is that in the old days, like in the 70s, what you had was a fairly lengthy fasting period anyway. That's why you have the term breakfast, right? So you eat dinner at 6 p.m. and you eat breakfast at 8 a.m. It's 14 hours of fasting as your baseline, right? And that's every day without even thinking about it. Now it's kind of spread, right? Sachin Panda has done all these studies about how long people actually eat, and it's like, you know, constantly. The minute they wake up to the minute you go to bed, it's almost 15 hours a day that people are eating. I think that's gotten so bad that when you squish it back to a normal sort of 16-8 sort of thing, because 14 hours and 16 hours, like 14 hours was sort of baseline in the 70s, and 16 is just a little bit. But because it's gotten so bad, when you squish it back into that, we do see a lot of people who benefit just from that one intervention alone. And, to me, it's always about practicalities. That is it easier? So if you have people, for example, say two strategies. One is counting carbs, which I think can work, versus counting the number of hours that you don't eat. It's like, it's so much easier to tell people between 12 and 8 is your eating window, everything else don't eat, versus look at everything that you eat in the day, try and calculate how many carbs it is, and add it up so that you have some arbitrary less than, right? Less than 120, less than 50, less than 20. It's so difficult, whether you're counting calories or whether you're counting carbohydrates or doing macros, right? It's just so difficult to do. It's so much easier to say things like only eat between this hour and don't eat anything that came in a box kind of thing, right? Those, to me, that's practical, useful advice as opposed to say, let's get your carbs from 55% to 40%. It's like, it's so difficult. It's just, and I'm not saying that it can't work. I think it can work. I just think it's so hard to implement when you're seeing patients sort of every few minutes, right? Like, how are you going to do that from a practical standpoint, right? It's not feasible.
I completely agree. I mean, I think there is no simpler instruction than when to eat and when not to eat. And yeah, I think, combining these things can often be incredibly potent. I don't know. I've seen mixed results on 16-8, truthfully. I've seen some patients who have really significant improvement. I've seen other patients experience no improvement whatsoever. We typically will push that window tighter, 18-6, 22-2. Again, the tighter you push it, the more benefits you see. But I've really seen no substitute for what I call intermittent fasting. We use that terminology very distinctly. We reserve the term time-restricted feeding for up to 24 hours of restriction, but we use the term intermittent fasting to describe what I think that term means, which is you intermittently, periodically, i.e. fast. And fasting can be a complete reduction of calories, or it can be a hypocaloric fast. So you can consume somewhere between 20 and 40% of your normal caloric requirement for a period of time. You typically look at 3 to 7 days, and you repeat that cycle. What type of protocols do you use for intermittent fasting with your patients?
We use all of them. So because we're predominantly clinical, we'll individualize. So the things we take into account is one, how severe is it? So a severe type 2 diabetic on a huge amount of insulin, we're going to give a more stringent schedule than somebody who's just sort of pre-diabetic and wants to sort of prevent it from getting into diabetes. So the other thing is how old they are and how willing they are to do it. So we see a lot of people who are in their 80s. We have people in their 80s doing we had a lady who was like, I think she did 61 days, right? And she's not young, right? And we have people in the 80s Nothing, yeah. That's what she said. Although sometimes when you actually go into it, sometimes they have little things here and there. But she said she did 61. We have lots of people who do long fasts like that, and they don't have any problems. We monitor them very closely, though. But generally, we don't do that. There's no point taking that much risk a lot of times. She actually just felt good on it, so that's why she did it. But we don't usually push it long like that. But we will if we need to. But it depends on how quickly. So it's how severe is it? How old the patient is, and how urgent it is. Because we have people who have a ton of disease, right? And we're like, if you don't get this diabetes fixed like right now, you're going to be in a world of trouble. So we had this guy, he was actually in his 40s. He had a non healing diabetic foot ulcer for like a year, followed by a plastic surgeon. So he actually came into the hospital, and I saw him because I was seeing him for his diabetic foot infection, gave him antibiotics. I said, your problem is not your foot. Your problem is your diabetes, right? Because the reason you have this foot ulcer is because of diabetes. You don't get foot ulcers if you're not diabetic, right? Unless you have severe PVD or something, right? But the point is that if it's the diabetes which is causing your foot ulcer, you got to get rid of your diabetes. So I talked to his dad because this guy was like in his 40s, and the dad was Greek Orthodox. So his dad was like, "Oh yeah, 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 let's do this." So we put him on, and we put him on fairly strict restriction. We started him, I think, on a week of fasting and then 36 hours 3 times a week. And that ulcer healed like within 3 weeks. It was like ridiculous how quick that thing just healed up.
You led with a single week of fasting before cycling 36 hours weekly, or did you lead with the 36 hours?
No, I started with the 7 days and then we did like 36 hours because it was severe. Honestly, he was going to get his foot chopped off at some point.
You're definitely more aggressive than I am because you're seeing much sicker patients. I never lead off with water only fasting for patients. Usually, what we do is we push the windows of time restriction, which, as I said a moment ago, I'm not convinced there's huge benefit in time restriction. I think there's some benefit. I think the biggest benefit of time restricted feeding is the psychological one. It's breaking the cycle you just described earlier, which is people think intravenous access to food is essential for life. If they go more than 2 hours without a meal, the sky is going to fall. And so in many ways, time restricted feeding is just a way to prove to them that that is total nonsense.
I actually think that the long fasts do exactly the same thing.
Well, yes, but you can't lead. I mean, at least for me, I haven't tried leading off with that. Talk me through like that particular patient. So first of all, let's grant it that he now has agreed to try this. This is a patient who is not entering a fast the way I would enter a fast, which is I usually spend a week in ketosis before the fast, which means I'm showing up in a fast with a ketone level of somewhere between zero point 0.5 and 1 millimolar of beta hydroxybutyrate. I sail generally pretty easily into these fasts, not all the time. This is a guy who's got a respiratory quotient of 1. He is a completely obligate glycogen consumer. He's probably not oxidized a fatty acid since Guns N' Roses were popular. This is a guy who's going to be in for a world of hurt when you strip food away from him, because within a few hours, he's going to sense, his liver will sense glycogen levels are low. It's time to eat. So how are you getting him through that?
There's no easy way. We just tell him this is like going to suck for a week because you're not going to feel that great. You're going to be hungry and all this sort of stuff. It was the urgency. And I'll tell you that people actually can do it. Quite a lot of people have. We've done it on a number of people. And most of the people, as long as you warn them ahead of time that it's going to be tough, they get through it. But the thing is, the psychological, if you've done a week, you know that 24 hours is like nothing. And you get into ketosis so fast because that's the fastest way to get into ketosis, right? Is just to fast. There's no faster way you can do it than that. So it's not easy, but there's reasons why. And that's why I say it's important that everything is individualized, because I'd never do this to somebody who's like 40 and has an A1C of like 6.0. It's like, why put yourself through that, right? Do it gradually. You have no time restrictions. This is a guy who's actually coming into the hospital with diabetic foot ulcers that were getting close to osteomyelitis, right? It's like, it's a much different situation than not, right? I'm trying to make sure that somebody he doesn't wind up getting a bad infection and somebody wind up chopping his foot off, which is why I was super aggressive in that case. I've heard stories of other people who have put patients on starting sort of 10-day fast and so on. So they don't all do well. They don't all get through it, but it's an option. That's all I'll say. And I hate to be prescriptive, like, oh, you have to do this, you have to do this. And this is what seeing patients does to you. I find that the people who are super dogmatic are the people who never see patients.
Yeah, I can't agree with you more.
Yeah, because patients always prove you wrong. You think your stuff works. Well, like 40% of your patients it doesn't work in, right? So then I'm never like, "Oh, you have to do this. You have to do this," because it's like, "Yeah, I know it doesn't work." Like carb restriction. Like some people it really does work well, and some people it really doesn't work that well. And the studies show the same thing, right? Chris Gardner's study. If you look at the splay between low fat and low carbs. Some people do great on a low fat diet, and some people do terribly on a low fat diet. It's the same diet. Same with the low carb. In general, the low carb people do better, but when you look at the individual differences, and that's why people get on Twitter and they start talking about, oh, it's all about this or it's all this. And then it's like, I know you don't treat people because if you actually treated people, you'd never say stuff like that. You'd never get on somebody about taking the opposite position because you've been proven wrong so many, like every day I'm proven wrong, like something doesn't work. And that's why I'm always like, let's do this, see if it works. If it doesn't work, we're going to adjust it. And then if it works better, then we're going to keep doing that and we'll adjust it, right? And that's where the kind of art of medicine comes in. So you can start, but to me I always tell people like there's two options when you do fasting. It's like going into a pool. You can wade in or you can cannonball in, right? And both are acceptable. One's a big shock to the system, but it works, and the other is not as big a shock, and it still works. For this particular patient, that was one of the few times, because most of the time it's not that urgent, that I did recommend, oh, you just got to do this. And his father was on board, and he was on board, and we monitored him super closely. We actually started him in hospital because he happened to be in hospital anyway, so I put him on clear fluids, right? And then just told him, don't take anything with sugar, just water, and he did very, very well. And I've done it to a few other people with diabetic foot ulcers as well, because I consider that one of the more difficult. Like that's something that you really have to take care of. And I always think diabetic foot ulcers to me is fascinating because it's like if you think about this overflow paradigm, it's like why do diabetics get these infections that nobody else gets? Why do you get mucormycosis? Why do you get osteomyelitis? Why do you get diabetic foot ulcers? You don't get like foot ulcers from ischemic cardiomyopathy foot ulcer, right? You don't get that ischemic cardiomyopathy mucormycosis. It's because what you're doing is you're putting all this sugar into the body. Then when the blood glucose goes up, you give them insulin to really jam that sugar into the body, right? And the body takes it, and your liver gets all this sugar and starts sending it all over the place. Pretty soon, your whole body is so full of sugar that everything just starts rotting. And that's why you get the kidney disease, that's why you get the eye disease, and that's why the bugs just love it because there's so much sugar and nutrients everywhere. So they get in your foot and they never go away. Those foot ulcers never heal. You get these weird infections that you never see anywhere else. You get the rashes, the acanthosis, and all that. It's just you got way too much sugar. It's all about the whole body sugar and not just the blood sugar. That's the real shift in thinking and paradigm that to me makes a lot of sense. And as soon as we're able to empty out all that sort of sugar, and I always use the analogy of a sugar bowl. We're just filling up the sugar bowl. You got to empty that sugar bowl, and then the sugar won't spill out. And that's why it works. And the fasting is the same thing. So we'll individualize it. So based on all those sort of factors, like including what they want to do, right? You got to talk to people and say, what are you willing to do? Right. And a lot of people aren't willing to do a long fast, but a lot of